Good morning, everyone. Yes, I was just saying that we are going to maybe giving some answer to Professor. Just a simple scheme. How renal denervation it works, the mechanism. We have afferent and efferent nerves, and we are providing ablation. We are reducing the sympathetic tone, reducing the output of renin, and we are reducing the blood pressure. This is simple. Clinical context. As we already seen by the other colleagues, in recent sham control trials, RDN showed real efficacy by reducing the blood pressure by 10 to 15 millimeters of mercury, is a sustained reduction up to 6-12 months, and is a durable blood pressure lowering independent from the medication adherence. So which is the rationale for patients having atrial fibrillation? Atrial fibrillation patients usually are having increased sympathetic tone, so it's just the triggers for atrial fibrillation and for the remodeling of the heart. So this sympathetic activity, we can just ablate it. We can reduce the facilitating action with atrial fibrillation initiation and perpetuation. We are going to reduce the central sympathetic driver, reducing the norepinephrine spillover that is an upstream antiarrhythmic effect. Which are the studies that are giving the evidence? There is a multicenter randomized control study, including 392 patients with paroxysmal atrial fibrillation and suboptimally uncontrolled hypertension. Patients randomized 1-to-1 to pulmonary vein isolation alone or pulmonary vein isolation plus renal denervation using radiofrequency catheter. Primary endpoint was freedom from atrial fibrillation, flutter, and tachycardia at 12 months. Secondary endpoints including blood pressure control and echocardiographic change. From the point of view of arrhythmia outcomes, it's clear from this graph how the patients that were receiving pulmonary vein isolation associated with renal denervation were having low risk of recurrence of atrial fibrillation, flutter, and tachycardia. For the blood pressure effects, it's clear how systolic and diastolic blood pressure at baseline 6 months and 12 months were clearly controlled. And the blood pressure reduction was very evident for the group of pulmonary vein isolation associated with renal denervation. Additional results about the structural remodeling, patients were receiving renal denervation had LA diameter reduced by 2 millimeters and septal thinning increased by 2 millimeters. Hospitalization for patients receiving renal denervation was very less for cardiovascular reasons. And about the safety, the procedure-related complications were similar in both groups, just to indicate that there is no excess risk when we are adding renal denervation to the normal ablation. Is there any meta-analysis? Yes, 6 studies, 725 patients total, atrial fibrillation plus minus renal denervation in uncontrolled hypertensive patients. The recurrence of atrial fibrillation was calculated by 32% of relative reduction versus patients that were receiving no renal denervation. No increase in complication, adjunctive renal denervation is considered safe. And for the blood pressure effect, systolic blood pressure reduction average minus 12 millimeters of mercury. So again, adjunctive renal denervation plus PVI is safe and improves clinical outcomes in atrial fibrillation patients with hypertension. In summary, in hypertensive plus atrial fibrillation patient, renal denervation associated with ablation significantly improves rhythm outcomes without increasing complication. Benefits include higher 1-year atrial fibrillation-free rates and greater blood pressure reduction. RDN's antiarrhythmic effect is attributed to sympathecolysis and blood pressure control. Let's see for heart failure patient. If we are considering the heart failure patient with reduced ejection fraction, we have the sympathetic tone that is increased and the activation of the RAS system is augmented. So we are assisting to ventricular remodeling during time and dysfunction of the left ventricle. So usually we are just using the therapy, the standard therapy that is acting to reduce the catecholamines effects that are worsening the heart failure. So beta blockers that are acting to the nervous system and are increasing the outcomes by the data. So renal denervation, reducing the renal nerve input, is reducing the central sympathetic tone with the reduction of neurohormonal activation. So targeting sympathetic overactivity by beta blocker and renal denervation can be a key component of heart failure with the reduced ejection fraction management. Let's see which data we have. This is a trial, RDT-PF, single center, control randomized, 25 only patients with the preserved ejection fraction. Left ejection fraction was more than 50, diastolic dysfunction. They were randomized 2-to-1, renal denervation versus medical therapy. Main result, there was no significant difference at 12 months for quality of life, peak of VO2, NT-proBNP, diastolic and structural measures were similar. Early 3-month signals increased peak of VO2 and better diastolic dysfunction, but clearly underpowered. So renal denervation was safe, but no demonstrable improvement in heart failure preserved ejection fraction outcomes. What about the patient with reduced ejection fraction? Single arm, pilot, 39 patient total with ejection fraction less than 40%, NIA class 2-3, chronic kidney disease, evident reduce of proBNP marker, 0.006, improved glucose tolerance as result, main result. About functioning and remodeling, no significant change in left ventricular ejection fraction, 28 to 29, no change in 6-minute walk distance test. Safety and take home, RDN technically, again, feasible and generally safe, only minor functional effect in heart failure with a reduced ejection fraction patient. Meta-analysis, yes, we have meta-analysis, 5 randomized controlled trials, total of 177 heart failure with reduced ejection fraction patient, renal denervation versus control. There is an increase about left ventricular ejection fraction of 6.3%, meaningful left ventricular function gain. Functional capacity, there was an increase of 61 meter average of 6-meter walk test, and better exercise capacity. Biomarkers, again, proBNP significantly improved. Benefit for heart failure with a reduced ejection fraction patient. From the point of view of neurohormones, proBNP and NT-proBNP levels dropped significantly. Remodeling RDN led to reduction in left ventricle end diastolic diameter and left atrial diameter. Functional status, NIA class improved, and the functional was increased markedly. So in summary, for heart failure, safety is safe, no deterioration in renal function. There is a clear improve of left ventricular function, even if signal benefit is only demonstrated in small studies. There is a potential adjunct in heart failure, but larger outcomes trials are needed. Let's see about obstructive sleep apnea. The mechanism is very simple. The intermittent hypoxia is just creating an acute increase of sympathetic activity and blood pressure, especially during the night. When there is a redistribution of fluids, most of the time there is accumulation that is increasing, let's say, the high-rate obstruction, especially for hypertension patients. So this overactivity of the sympathetic tone links the obstructive sleep apnea with cardiovascular disease. So the role of RDN, again, can reduce the sympathetic tone, reducing the nocturnal blood pressure increase and fluid retention. It can maybe improve the obstructive sleep apnea burden. There is one study, randomized control study, 60 patients with resistant hypertension and moderate severe OSA with an index more than 15, randomized renal denervation versus medical therapy, primary endpoint, office systolic blood pressure 3 months, as secondary endpoint OSA severity. BP, blood pressure, was significantly reduced in the renal denervation group. For the severity of obstructive sleep apnea, actually the index decreased from 39.4 to 31, but was significant. So between the group, the change of the index was not so evident but significant. So patients with resistant hypertension, the obstructive sleep apnea, showed a meaningful drop in apnea-hypopnea index after renal denervation, indicating reduced sleep apnea severity. Review. There is evidence for 5 studies, a systematic review for OSA patients, mostly with hypertension. There is no significant change of the index, so the effect on OSA severity is not confirmed. The blood pressure was reduced with an average of 7.5 milliliters of mercury on daytime and nighttime. And the procedure was safe, so no major procedural complication reported. Renal denervation reliably lowers blood pressure in hypertensive OSA patients, but its impact on HAI remains uncertain. In summary, sympathetic overactivity is a unifying factor in hypertension, AF, and heart failure, and OSA. RDN interrupts neural nerve signals, dampening systemic sympathetic tone and RAS activation. This shared mechanism explains why renal denervation can benefit multiple conditions characterized by excess sympathetic drive. Give me 1 minute more. I decided to add even this kind of population. There is a recent publication done from University of Verona that is just evaluating patients with chronic kidney disease. As we know, the chronic kidney disease, I mean, the eGFR less than 40 is a contraindication for this procedure. So this study is evaluating 100 patients in the last 10 years with a wide CKD spectrum, with the GFR that was going from 60 to dialysis. Primary endpoint, 1 month safety, blood pressure change up to 3 years, long-term eGFR trajectory and hypertensive drug burden. Key result, no major vascular complication or procedure-related kidney failure, few contrast-induced AKI and femoral pseudoaneurysm that also successfully managed. Blood pressure demonstrated having a good trend of reduction. Renal function, most important, mild, non-significant eGFR decline at 3 years, from 1 to 2 that is expected in hypertension patient. So 6 dialysis patients, this is another point important, successfully bridged to kidney transplantation after blood pressure improvement. I will go directly to conclusion. So in conclusion, renal denervation effectively lowers blood pressure by reducing renal sympathetic signaling. Beyond hypertension, RDN may enhance atrial fibrillation success, improve left ventricular ejection fraction in patients with reduced ejection fraction, reduce OSA severity, offers additional benefits in chronic kidney disease patients. So RDN is generally well tolerated. Ongoing trials will further define its role in this special cardiovascular population. Thank you.